me several months ago, and said, I really want to write an abstract for NatGo. Will you work on it with me? And I said, of course. And then we threw around ideas about what we should do, and then Marissa did all the work. So I want to thank Marissa, obviously. So a couple of things. We have no conflict of interest to disclose, and we wanted to acknowledge Dr. Pruitt as well as Sarah Toronto. Dr. Pruitt has spoken widely on this conversation on increased risk donors overall, and actually presented at AOPO. And this kind of culminated in, Marissa and I were talking about this abstract, and AOPO was talking about this as a plenary session activity as well, and then the Alliance wanted to do something on it. So it was this great ability to pull all this data together for all of these different forums so we could educate the community about the increased risk donors, and specifically today about the increased risk in IV drug abuse that we're seeing, that I'm sure many of you are seeing as well. So in New England, we've been hit particularly hard. This is a picture of the governors of all the 6 New England states coming together to address the opioid epidemic. And this obviously shows the impact that it's having, that top lawmakers in the states are putting together resources and money to try to treat this epidemic. And obviously there's national, on a federal level, there's money being committed to try to fight this epidemic as well. And some of you might have seen this this documentary that was done, it was on HBO, that really kind of illustrated the types of people that we're seeing now that suffer from heroin addiction and the lifestyle that they live. And everybody thinks of Cape Cod as this perfect vacation community. Half of us go there for the summers in New England, and the heroin epidemic is hitting them particularly hard. And these are not patients that we would have thought of 20 years ago or 30 years ago as heroin addicts. These are patients that come from middle-class families, that have jobs many of the time, that have families that love them and care about them, and see them struggle through their addiction. The U.S. News and World Report published this a couple months ago, and actually our CEO in New England, President and CEO Alex Blazer, was quoted in this article, because clearly we're seeing this number of donors rise as a result of the heroin epidemic, both on a national level as well as in regional pockets of the United States. And Marissa's got amazing data that she's going to show that illustrates this, I think, very, very well. And this huge increase also has an impact on donor families as well. These patients, with their families who have battled through this addiction with them, and are often not surprised when their loved ones overdose and end up being brain dead or potential DCD donors, because they've often been through it before, and they see this as really the one shining light that can come from the experience that they've had as their loved one battled through their addiction and ultimately lost and passed away and became a potential organ donor. Interestingly, in New England, and I don't have any national data on this, but we see a higher rate of patients that have signed up in the donor registry that are these organ donors that have overdosed. So it's about 60% of our donors that have overdosed that are registered, as opposed to about 50% in the donor population overall. So these are young, otherwise healthy patients with good organ function often. And my colleagues from New England are here, and they live this every day out in the ICUs and talking to families, and they can describe this, as I'm sure many of you can as well. And with that, I'm going to hand it over to Marissa, who's going to go through a lot of really, really great data. So, Marissa.
He gave me the clicker with no instruction. Oh, there we go. Yeah. Thank you for having me here today. I'm really excited to come talk to you all. And Chris is too generous. I did not do all the work. He flew all the way down here to help me present, so I really appreciate his help. So we have an epidemic in the U.S. That's what it's been deemed anyway. Since 2000, we've had a 137% increase in drug overdoses, mainly opioid overdoses. Opioids such as prescription painkillers, heroin, fentanyl. How has this escalated? Where has this problem come from? It starts not where you would think. This isn't in a back alley or a street issue. This is happening to younger people, people who go to the doctor for a broken ankle and they're prescribed opiates, and they just keep on getting prescribed opiates. They somehow now have a tolerance buildup. They're addicted. They continue to take more and more. At some point, the doctors stop prescribing them. Then what happens? Well, there's the black market. You get them from friends. You try to find opiates somewhere because now you've developed this addiction. And ultimately, what leads to heroin is the fact that it's cheaper, unfortunately. Somebody I talked to that was a member of the DEA drug task force said a 16-year-old can get heroin easier than they can get a case of beer, and cheaper, which is crazy. So the CDC reports most people who become addicted start with painkillers. They are non-Hispanic, young, white males, live in populated areas. People that also have other substance abuse, such as cocaine or other non-IV drug use, maybe. Heroin use has more than doubled among the younger population in the last year. And CDC reports about 90% of people who use heroin also use at least one other drug. So again, looking at some CDC data, it was an interesting comparison. I remember when I was younger hearing all about HIV, and it was a huge deal. That's sort of where the heroin epidemic is going. It's supposed to be reaching a level similar to the HIV epidemic when it was at its peak, and that's really scary. If you look at the map here, the map just shows geographic distribution of the overdose deaths in 2014 per 100,000 population. Oh, and on the last slide, I don't know how to go back. Oh yeah, so this was a really scary statistic. If the CDC reports that on average 125 Americans die every day from opiate abuse, drug overdose. That's more people than die waiting for a life-saving organ transplant. Last year, the DEA did their annual national drug threat assessment survey, and basically they answer a bunch of questions about what are the drug threats in your area. In 2015 was the very first time that heroin was reported overwhelmingly as the major drug threat in the area. And if you look here where I've circled, the majority of the places that reported were up in the northeastern states. So, what do we know as the OBTN about these donors? Well, we collect in 2 different places information on donors and drug overdose. In DonorNet, we collect whether or not the donor had a history of IV drug use, which is good, except we don't know the duration of the history. Was it recent, 6 months ago, 10 years ago? How long was the history? Were they users for a short period of time, one time, 8 years, 10 years? Nor do we collect the drug. So who knows what other IV drugs are out there, but we don't collect that level of detail. On the deceased donor registration form, we collect as a mechanism of death whether or not the donor died of drug intoxication as a mechanism of death. Again, limitations, we don't collect what the drug was. Did they die from using it for the first time? What was the dose that they took, etc. So we are limited in some of the data that we collect. So here's a graphic. I thought it was a pretty shocking graphic to just put together on a slide. But if you look since 2007, when we have complete DonorNet data, through the end of last month, this graph shows the trend in deceased donors recovered in the U.S. that have a history of IV drug use. The blue bars are the numbers, and the red line indicates the percentage. So as of the end of last month, 11.5% of all deceased donors recovered in the US are reported with IV drug use history. So if we recall, the CDC made some declarations about what the composition looks like of the overdose deaths that they have. So they said, it's predominantly younger, white males. So we just looked at some of the donor characteristics just to see if things were the same for the donors as they were out in the national overdose population. So as you can see, IV drug use donors are significantly more males than there are in the non-IV drug use population, significantly more white. We looked at PHS risk status, and overwhelming majority of the IV drug use donors are also classified as PHS increased risk. 40% or so are HCV positive compared to about 2% of the non-IV drug use donors. If we look at mechanism of death, and there are multiple mechanisms, I just looked at drug intoxication versus the rest. Statistically, a lot higher in IV drug use donors. Cause of death, anoxia, overwhelmingly so. And again, the CDC stated that 90% of heroin users have abused another drug. So we collect a few of these. So if we look at history of cocaine use, IV drug users, statistically higher proportion of drug users also use heroin. Other non-IV drug use. Alcohol use, it doesn't look like it's that big of a difference, but the numbers are kind of high, so there was some significance there. One thing that may not be surprising is there wasn't any difference in the distribution between brain dead and DCD donors in these two populations. IV drug use, I think, was 15% or so, and the non-IV drug use donors was about 17% DCD. So if we look at the organs transplanted per donor for these deceased donors that have this history of IV drug use, you can see starting in 2010, you see a little bit of a spike, and it goes up to about 2.7. If you look at the graphics that we have later on, you see 2010 is the year where we start to realize there's an issue, something's going on. The trends start, the percentage of donors dying with drug intoxication or with a history of IV drug use start to increase. As of 2010, it stayed pretty steady, 2.7, 2.8, somewhere around there. So the organs transplanted per donor has remained constant regardless of the growth of donors. So additionally, we looked at the average age of these two donor groups, the KDPI, and the organs that were discarded, recovered, or transplanted per donor. So first we just looked at all donors. Let's take all donors, let's just split them between those that have a history of drug use and those that don't. Those that do have a history of drug use, significantly younger, 33 years old versus an average of 40 years old. Significantly lower KDPI scores, 40% instead of 55%. There is a statistically smaller number of organs recovered and transplanted but not discarded. So if you recall, a lot of those, about 40% of the IV drug use donors were HCV positive. So we want to check out what these characteristics look like, excluding those donors that are HCV positive. So if we just look at the HCV negative donors, we see similar results. IV drug use, those donors were still a lot younger, 32 instead of 40. KDPI is still significantly lower for those donors that are drug users, and all statistically different, except notice the reversal in the organs recovered and the organs transplanted per donor. So in the previous slide, the non-IV drug users have a greater number of organs recovered and transplanted per donor. If you factor out HCV positive, now the IV drug users, those donors have a significantly higher number of organs recovered and transplanted. It completely flips when you take HCV positive organs out of the equation. And we also just looked at PHS standard risk. Let's exclude the high-risk donors. We already took out HCV positive, which is probably a good proportion of the high-risk donors, but just to see if we could get rid of anything else. By doing this, the mean age of these two groups is now the same, and the number of organs discarded, recovered, and transplanted per donor is the same. However, the average KDPI is still significantly lower for the group of IV drug use donors. Take it one step further, and let's look at the younger age group. These donors, the IV drug use donors, the increased risk donors, they tend to be younger donors. And we just saw from the slide before, once we adjust for PHS increased risk and HCV positive, the mean age is the same. So let's just look at these young donors now, HCV negative, standard risk, young donors. If you see now, they're very similar. KDPIs are very similar. The organs discarded and recovered per donor, similar. There is an increase in organs transplanted per donor for the non-IV drug use donors, 4.3 versus 3.6. So what does this tell us? All else remaining the same, if we look at these IV drug use donors that are not HCV positive, that don't have another risk factor that would have made them increased risk without their drug use, these donors are younger, they have better KDPIs, these are pretty good donors. So I put this up here just to remind everybody of the regions, and maybe you all know all the regions, I still don't. So just as a reminder of where all the regions are. And then if we recall, a lot of the fun stuff that's going on here is happening in the Northeast, right? So if you looked at the CDC map or the Drug Enforcement Agency responses to the heroin threat in their area, it's predominantly here in the Northeast. So just remember, this is basically regions 1, 2, 9, and 10. So back in 2007, when we first started collecting whether or not donors were reported with a history of IV drug use, this is the distribution regionally on how regions were recovering donors. They range from anywhere between 1.6% of donors recovered in region 7 to 5.1% of donors recovered in region 1. National average 3% of donors. So back in 2007, this was pretty uniform across the board. 5% or less of donors being recovered in every region had a history of IV drug use. So let's fast forward a little bit to a couple years ago. Here's 2013. In 2013, now, instead of going from 2% to 5% of donors, we now are 4% to 12% of donors. And this varies from region 3 to region 1. And if you look, which regions have a higher percentage of donors recovered with IV drug use than the national average? Regions 1, 2, 9, and 10. That's the Northeast area. 2014 gets even higher. Now we go from 4.5% to almost 19%. Again, we've got regions 1, 2, 9, and 10. Now 6 creeps up there a little bit, but all of those northeastern regions are still, they have a higher percentage of deceased donors recovered with IV drug use history than our national average. Let's go one more full year. This is crazy, right? 22% of donors recovered have a history of IV drug use. That's crazy. And again, all 4 of the regions in the Northeast have a higher percentage of their donors recovered with IV drug use than the national average. But now this still ranges from 7% to 22%. So why so much variability within the regions? Oh, and I added 2016. So we have data through the end of last month. So for half of 2016, if you go back, 25%, a quarter of all of these donors being recovered are being reported with a history of IV drug use. I mean, you have to think, is this trend going to keep going? Is it going to level out at some point? What do you do when all these donors have this drug use history? Let's figure out the best way to maximize organs recovered. So just to kind of show a wow factor here, if we look from 10 years ago until now, this is the change regionally in the number of donors with an IV drug use. So if you look at Region 4, for example, compared to 10 years ago, about 83% more of their donors recovered have a history of IV drug use. If you look at Region 7, 600% more of their donors being recovered have a history of IV drug use as compared to 10 years ago. Nationally, we're at about 2.5 times as much. And then we have some heat maps. Had this really cool dashboard put together in Tableau, and if anybody attended my session yesterday, you know I'm kind of a data nerd. But so I tried to recreate it here in PowerPoint so the audiovisual guys didn't give me a hard time. So we started in 1998 and we looked, and also in the beginning I mentioned there were two different ways that we can look at information on drug use. We can look at the IV drug use field in DonorNet, or we can look at the mechanism of death as drug intoxication. So far I've really looked at the IV drug use field in DonorNet. But just to give you an idea that essentially everything is exactly the same, I just put together some heat maps over time. So we'll do a time lapse, and these heat maps show the percentage of donors recovered in that area that have drug intoxication as their mechanism of death. So in 1998, everything's kind of cool and green and real low, and you'll notice as the percent of donors with drug intoxication increases, you'll start to see some yellows and oranges and reds, and like it's getting hotter, right? Your hot spots. So I'll just go through here. 99, 2000, 2010 is when we start to see something, right? That's about where we are right now. So as of 2015, if you notice, we've got that whole northeastern patch of states that are pushing 15% or more of their deceased donors recovered are indicated as having drug intoxication as their mechanism of death. And if you just remember what this looked like in 99, right, 15 years ago, the entire map was green. It was almost nothing. And in a matter of really 5 years, you have this dramatic change. So what happens when we do use these organs? How well do they do, right? So as Chris mentioned, Dr. Tim Pruitt has been working a lot on studying the increased risk nomenclature and what impact that's had by labeling an organ increased risk. Well, similarly, if you, and I am assuming because I'm a statistician and not anything clinical, but if you were to offer an organ to a parent of a child and you say the organ's great, the donor's awesome, they died with a needle in their arm and had some heroin there, but really it's a good organ, I'm assuming that most parents would be hesitant to say, yeah, let's take this organ. Why? That we don't have data that proves that these organs do worse. We barely have data at all because this has just started taking off. So I looked at some short-term graft survival outcomes, looking at organs transplanted during 2012 and 14, and I looked at 6-month, 12-month, and 18-month post-transplant graft survival, just to see. Let's look at these two groups separately. Let's get rid of the HCV positive, just look at the HCV negative organs, and see how these grafts do in these recipients. Well, if you look, the only place where there's really significance is in kidney and lung. So first of all, and I didn't include intestine, heart, lung, or kidney, pancreas, because the numbers were small. But for pancreas, liver, and heart transplants, 18-month survival, identical. So transplant the HCV negative IV drug use donor, and your outcomes at 18 months are similar than the HCV negative non-IV drug use donor. And that has increased risk donors in there and everything. The only thing we're looking at is taking out HCV positive donors. Actually, for kidney, 18 months post-transplant, the graft survival is significantly higher for recipients of those IV drug use organs. For lung, it's significantly less, by 5% or so. So if anybody were to want evidence of why we shouldn't use these organs, I might argue that the only evidence you have is maybe you could use this to say, I don't want to transplant the lung. Otherwise, these organs are identical. So far, the outcomes are the same, and for kidney, they actually are higher. All right, so I'm giving you back to Chris now, but thank you, everybody, for hanging out with me.
So thanks, Marissa. I told you the data was very compelling. I just finished serving 2 years on DTAC, and if anybody's served on DTAC or has the chance, it's such an eye-opening experience, and they do amazing work. So we wanted to talk about, obviously what we're talking about here is risk of disease transmission. The data shows the outcomes, of course, but our biggest concern is, or the biggest fear is, that this patient's going to get a contracted disease, the recipient's going to get a disease. So I'm going to show you a little bit about data relating to that. So in the DTAC experience, 10 years of reports of transmission that has been deemed by DTAC as either proven or probable donor-derived disease transmission. You can see there in the column that's virus. Does this have a laser? No, I guess not. You can see in the virus column, there's been 42 cases in 10 years that were categorized as proven or probable disease transmission. And so, there's this fear that, oh, well, maybe, this is a huge risk to recipients if the donor dies with a needle in their arm. So that's the fear. The reality is that of all the donors out there, you can see that only 0.04% died, and only 0.14% actually had a donor-derived disease transmission for all transplants that took place during that 10-year review. So the numbers are actually very small. So the other problem with accepting these organs, I think, or pursuing these donors that a lot of people have, is that the fear of this high-profile case, or I'm going to accept this organ, I'm going to put it into my patient, and it's going to make headlines. It's going to be on the Boston Globe or the New York Times, and that's the big fear. So in 1985, as many of you know, there was a single transmission of HIV to all four organ recipients and tissue recipients. And it was within the window period of the screening, and it was antibody screening at the time, not the NAT testing that we have the ability to do these days. So then we started doing routine HIV testing, and this is the actual number. So the rate of actual transmission of HIV has been less than 0.03%, and then there were no further transmissions of HIV from that case in 1985 for greater than 2 decades. Pretty good, actually, in the number of donors that we had in 20 years. So then in 2007, there was another case of HIV and HCV transmission from a single donor. And this went to the liver, the heart, both kidneys. And so we're not saying, and I'm not standing up here saying that these donors don't represent some risk of disease transmission. I would never say that. There's a risk of transmission of disease with all biologics, human-derived biologic products. So there's never going to be zero risk. And even since then, we've had donors that tested negative for NAT, and then the organs went on to be transplanted and transmitted HCV into a number of patients, and then you test a sample that was drawn in the donor operating room and it tests positive for HCV. There have been cases in the literature of that as well. But let's look at what the actual risk is of all these donors. So, according to our serology testing, the 4th generation antigen and antibody testing and NAT testing, the window phase is here. You can see it. So for HCV specifically, if you do NAT testing on a donor, the window period is about 3 to 7 days from that exposure event. So if they have a needle in their arm and they overdose, and then 3 days later you draw serologies, the likelihood that that patient actually has hepatitis C virus is lower. And the further you get from that exposure event, the lower it gets. And to illustrate that a little bit graphically, I'm going to show you on the next slide, not this one. But if you have a donor that dies of an overdose, has a needle in their arm, and the NAT is negative, the chances out of 10,000 donors that donor actually has hepatitis C is 37.8 out of 10,000 donors. That comes out to 0.004%. And as you get further away from that exposure event, you can see that the likelihood that the patient will have a false negative NAT test drops off significantly. And if you get to the point of 10 days, it's almost non-existent, the possibility that patient would have hepatitis C virus and not be detected by NAT. So, what does that say? And looking at the 2013-2014 data that was submitted to DTAC of disease transmission events, you can see that these are the number of actual transmissions that were reported and proven or probable. So you can see there for hepatitis B in 2013, it was 2 donors. And in 2014, you can see it was 2 HBV and 2 HCV. 0 HIV transmission events in these 2 years. And obviously this comes when we are changing the PHS definition of increased risk donors and increase in nucleic acid testing performed by OPOs in this country. So the risk of an HIV positive transmission to a recipient is very, very low. And with HCV, it's also very low. And again, even when those infrequent events of transmissions to recipients do occur, the transplant centers can intervene. The treatment for hepatitis C, depending on the genotype, is 97% effective on average. HIV, there may not be a cure, but it's manageable. And as you can see from the data, very, very unlikely to actually happen, even with a donor that's increased risk. So even if there is an unexpected transmission, in that very, very low likelihood, the options for treatment are very good. And a lot of transplant programs now are considering, because of the increased risk of hepatitis C, number of hepatitis C donors, giving that organ to their hep C negative recipient and then treating with the hepatitis C drugs after the fact. Now, Marissa alluded to how information about increased risk is communicated to recipients, that you're presented with this offer. It's a donor that is 25 years old, and it's the liver, and it's working great, but the patient died of an overdose with a needle in their arm and what that risk is. Dr. Michael Volk put these slides together as a graphic to illustrate to patients what the actual risk is compared to other risks of transplanting those patients. And I think this really illustrates in a very good way that the risk is actually extremely low compared to other risks associated with transplantation or the risk associated with not receiving the organ and the risk of mortality on the wait list. So I think the words and how we communicate with these candidates that may be apt to decline the organ if it's presented in the wrong way are very real. And I don't have to have these conversations with recipients. Many of you probably do. But I think sometimes we can overstate things. So in summary, obviously the opioid epidemic has led to an increase in organ donation, and there may be an increased risk of disease transmission. But I think as OPOs, we should be aggressive in pursuing these donors and offering them out to transplant programs. We have a motto in New England, which is it's our job to make these organs available to transplant programs and let them decide what's best for their recipients. And so I think it does, I'm a huge fan of doing nucleic acid testing all the time, if it's available. And I ask you, I would challenge all of you in the OPO world, are you aggressively pursuing these donors as aggressively as you could be? Because is this widespread regional variation that Marissa illustrated so well due to the epidemic, or is it also due to maybe some of these donors aren't being pursued as aggressively as they could be in both brain dead and DCD donors? And that transplant centers should consider these donors from PHS increased risk donors and IV drug abuse. And I think with that, Marissa and I would be happy to take questions. Thank you.